Hello and welcome. I'm Elisa Hernandez, a librarian at Stanford Health Library. Thank you for joining us for our talk, Running Injuries, an update on treatment and prevention. It's my pleasure to introduce our speaker, Dr. Michael Fredericson. Dr. Fredericson is a professor of physical medicine and rehabilitation at Stanford University and is the director of PM&R sports medicine in the Department of Orthopaedic Surgery. He's also the co-director of the Stanford Longevity Center and the founder of Lifestyle Medicine. He is the head team physician for the Stanford track and field and swimming teams and a Tsai Human Performance Alliance member. Throughout the talk, please enter any questions into the Q&A box at the bottom of your screen. And at the end of the talk, Dr. Fredericson will answer as many of those as possible. Over to you, Dr. Fredericson.
Great, thank you. Yeah, so welcome everybody. Thanks for joining us tonight. We've already received quite a few questions, and I'll try to address some of them during the talk, and then we'll save some time at the end for ones that we weren't able to get to yet. The goal of this lecture is to review some of the latest scientific evidence in terms of the treatments and prevention strategies for common running injuries. This is what I call the big six, and these injuries probably account for 90% of the running injuries that come into my clinic. First, let's kind of move our way down. So we'll start up at the hip region with hamstring. And this is a little bit different than the type of hamstring injury that occurs. Let's say if you're running and all of a sudden you feel a pull. This is a more chronic injury, tends to occur right where the hamstring originates, up at this, what's called the ischiotuberosity. It's part of the pelvic bones. It's a more insidious onset. You may even think it's just lower buttock pain. You may not even think it's necessarily your hamstring. But when you run, it's going to be worse with faster speeds typically, and definitely if you overstride. So the anatomy is very interesting. You've got these three tendons that make up the hamstring, and they all insert on that bone there, the ischiotuberosity. When you develop this tendon, what we call tendinopathy, the tendon becomes thickened. And keep in mind that right next to the hamstring is where the sciatic nerve runs. So I'll show you another picture here. This is an MRI, this is the hamstring, and this is the sciatic nerve. So I think this is one of the reasons why this injury can be so painful, in that you often get some associated inflammation of the sciatic nerve. Now, this is what we call a histologic. So if we were to take the tendon and look at it under the microscope, this is a normal tendon. So you can see how the collagen fibrils are very normally aligned. This is what happens when you get a chronic tendon problem. And this really, although this is for the hamstring, this type of pattern occurs for all of these chronic tendinopathies. So that the fibrils become very disorganized, and that leads to a much weaker tendon. So why does this occur? Biomechanically, we know that during the late swing phase, so as your foot's in the air right before it's going to land, the hamstrings are contracting, but they're contracting as they're lengthening. And this seems to put the hamstring in a very vulnerable position, and this is what seems to cause a lot of these injuries. Now, I often see this associated, as I mentioned, with overstriding, because that can often put a chronic stress on that hamstring attachment. These are some tests that we've developed through the years to help diagnose this better, because as I mentioned, sometimes you'll say, oh, I have some buttock pain. And there's a lot of structures in that area that could potentially cause you pain. But these tests really help single it out and isolate whether or not it is, in fact, the hamstring. The cornerstone of treatment is really progressive strengthening. And you're going to hear that over and over again with a lot of these injuries. And there's a very systematic way in how you progress this, from more static to more dynamic, and then eventually to what we call plyometric, more ballistic or explosive types of movements. Now, let's say you do that, you've had really good therapy, you've progressed through that, but you're still having pain. So what else can we offer you? And this is where there's some different types of injection treatments that can often be very helpful to kind of get you over that plateau. Keep in mind, again, there's a lot of different nerves and vessels around this area, and that's why we do any of these types of injections using an ultrasound machine, so we can be very precise where we're going and not injure, for instance, the sciatic nerve that's very close to that area. Now, sometimes we'll use just a corticosteroid injection. So if there's just some swelling, what we call percutaneous edema around the tendon, but otherwise the tendon looks intact, this can actually be helpful. We don't like to put steroids around tendons very often, but just as a one-time treatment, sometimes this is all you need. If there's more involvement, the tendon's more thick, maybe there's some small tears there. There's a newer treatment called extracorporeal shockwave treatment that can be very helpful for a wide range of tendinopathies. And then another option is what we call PRP, or platelet-rich plasma, where we actually take some of your own blood, we spin it down, and we concentrate the platelets. And the platelets are very rich in your body's own natural growth factors. So we inject that into the tendon to really stimulate healing. And if all else fails, there are surgical treatments for this condition. Now, in terms of prevention, this is what's called this exercise. Somebody's holding your legs and then you're going forward so that the hamstring is lengthening as it's contracting. So it's simulating an eccentric contraction. If you do this exercise in a preventative way, it can actually help prevent hamstring injuries. So definitely something to incorporate into your cross-training program. So let's move down to the knee now. The most common knee injury we're going to see in runners by far is what's called patellofemoral pain, and it accounts for up to 25% of knee injuries that we see in sports medicine clinics, and it's definitely the #1 cause of knee pain in runners. The typical history, you're going to complain of sort of this vague pain around your patella or your kneecap. It's typically aggravated by flex knee activities, so squats, or going up or down stairs. But interestingly, often much worse going downstairs because the stress on your knee is actually higher going down than it is going uphill or down than going uphill or downstairs. There's typically not a lot of swelling. If your knee is showing a lot of swelling, then that deserves a more further workup because it may be more than just patellofemoral pain or what we call runner's knee. And sometimes there's a little giving way, like the knee gives out, but it's not the same kind of giving way as, let's say, you've torn your ACL. So it might give for a second, but then you feel okay. If it's really giving out, then again, you should be concerned about a more significant ligamentous injury. Now, why does this occur? And one of the main theories is that there's some maltracking that's going on. So in other words, as you bend and flex your knee, this patella that's right in the middle should stay in a pretty smooth line. So it should stay on what we call the train tracks. Anything that causes that to stray off the tracks can lead to unequal forces underneath the kneecap and create unequal stress in the cartilage and ultimately to the bone. Now, this is a study that we did with a fancy MRI scanner that we used to have at Stanford, where the patient could actually do a squat real time and we could look at the movement of the patella. If you're not familiar looking at MRIs, this might be a little confusing, but this is a cross-sectional view. This is the femur bone, and then the patella sits in this groove, the trochlear groove. And if you look here, it really looks like the patella is clearly maltracking or even so bad that it's subluxing. But what we realized when we looked at this more carefully is that the patella actually was not moving. It was the femur that was rotating on the patella. Now, this isn't the case of all causes of patellofemoral pain, but it is the cause for quite a few patients. And that's why we've really started to focus more on strengthening the hip to help the knee. Because if you have this excessive hip internal rotation or the adduction where the knees are coming together like that and the femur is rotating inward, that puts the patella out of alignment. And sometimes patients look fine when we ask them to do a squat, but when they start to run, then it really starts to manifest. So this is somebody that look fine initially on the left here, and on the right, as they've been running for a while, because of some weakness at their hips, things start to break down, and now we see this increased angle. It's called the Q angle between the femur bone and then the tibia bone here. And that's another force that's going to cause this maltracking of the kneecap. In terms of the physical exam, there's no one specific abnormality or test that defines this condition. You really need to do a very thorough exam, and it's really by coming up with a cluster of abnormalities that change the function of the patella, of this extensor mechanism. That really helps explain why you might have this condition. So, for instance, let's say you tear your ACL. We know there's one test called the Lockman's. If that's positive, we know you have an ACL tear. With patellofemoral pain, it's not as straightforward because there's so many different factors that can play into why you might have this condition. In terms of treatment, this is from a paper I published, gosh, over 20 years ago, but most of this still holds up, but I'm going to give you some of the new information as well. So let's go into some of the key things. Again, as I mentioned with the hamstring injuries, strengthening is really important. And there's, again, a very systematic way in how you approach that. This is an interesting study that I wanted to share because they took patients who have patellofemoral pain and they had that increased internal rotation and adduction when they did their squats. So those knees came together. And through physical therapy, they were able to correct that. So patients then had a very nice looking squat. However, when they asked them to go back to running, there was no change. Even though they looked great in the gym, when they went back to running, things were still the same. Those knees were still coming together. So this is why gait retraining has become very popular. And you can do it in front of a mirror. And the idea is to try and create this window between your knees. So you don't want those knees coming together. If you look here on the right, now there's a nice window there. So we really just give the patient some simple cues, tell them to try and activate their gluteal muscles, keep the knee forward. And by watching yourself in the mirror, your body can help retrain itself. Now, another way to help if decrease pain if you have patellofemoral pain is to change your foot strike. Now, I don't recommend doing this, all of a sudden. If you are going to make a change like this, it's really do it over several months because it takes time for your body to adjust to this. But we know that if you land on your rear foot, so you're a heel striker, this creates this extra bump here, and that creates an extra stress to the patella. Whereas if you're more of a forefoot striker, the blue line, you get rid of that initial jarring, and there's less stress, or what we call vertical ground reaction force that's being transmitted to the patella. So if you say, well, gosh, that's a little confusing. How do I go from a rear foot striker to a forefoot striker? A simpler way to do this that's going to work just as well is to focus on your cadence. So how often is your leg turning over? What is your step rate? And if you can just increase your step rate by about 10%, that can make a big difference in terms of your patellofemoral pain. Ideally, we want to get people to around 180 revolutions or about 9 a step rate of 90 for one leg per minute. But let's say you're at 60, you don't all of a sudden want to go to 90. So just increase by about 10% and see what happens. This is a study we just recently published, and it was actually using Botox or botulinum toxin. And the idea, one of the other theories of patellofemoral pain is that there's an imbalance in the quadricep muscles, and that the inner quadricep is weaker than the outer, the vastus lateralis. And so we spend time in physical therapy, not only improving the hip muscles, but also improving this balance between the quadricep muscles. So what we did, rather than focus on just strengthening this vastus medialis or that inner quadricep, we actually put Botox into the vastus lateralis. So we temporarily shut that down. What the Botox does is it temporarily paralyzes muscles. That's why it's good for things like wrinkles, because it lets the muscles relax. And over time, we found that by doing that, it gave the inner quadricep, this vastus medialis, time to catch up to the vastus lateralis. And then their patients' tracking improved, their pain improved. And even though the Botox only lasts about 3 months, we followed patients up to 3 years, and 2/3 of them were still doing quite well. So I think once you can address this imbalance, there's a good chance it will hold up over time. Unfortunately, don't go running to your doctors asking for this, because it still isn't approved by the FDA for this purpose, and so insurance is not going to pay for it, unfortunately. That might change in the future, but we still need a bigger randomized controlled study and for the FDA to really say this, is something that they're going to put their mark on, and then insurance companies will come around. I mentioned this, I'm not going to spend a lot of time on it, but just because you have pain in the front of your knee doesn't necessarily mean it's patellofemoral pain. This is a whole list of other things it could potentially be. So, just make sure you're going to a good sports physician who's going to do a very detailed exam to rule out or in some of these other conditions that might have a different treatment approach. Now, another condition around the knee that's quite common in runners is called iliotibial band syndrome. It's the second most common injury in runners. And this is going to give you pain more on the outside, on the lateral side of your knee. Typically comes on as more of a burning pain, more of a tightness. So you start off running and you feel pretty good, but before you know it, your knee just kind of tightens up, or you get that burning sensation and you just can't keep running. What's interesting though is oftentimes you go back home, you stretch out, you start to feel better. You think, oh, okay, I can go back and run the next day. And then let's say a mile and a half or so, the symptoms come on again and you got to stop running. So that reproducibility is another sign of IT band syndrome. This is a study that looked at the biomechanics and what may be going on as to why patients develop this. And it's actually very similar to what I showed with patellofemoral pain. You can see how that knee is collapsing in. The mechanism is a little bit different than patellofemoral pain, because there's also some things going on with knee internal rotation, but the basic idea is the same. And these kinematic differences that occur in runners who have IT band are associated with greater strain on the IT band, particularly during when that foot just lands, during that initial what we call support period. And so then the IT band rubs against the outside of the knee and it creates this friction, and then that can become very painful, gets inflamed, things get tight, that burning sensation. Again, a good physical exam is very important. The red is typically where patients with IT band will hurt, but it's very close to your joint line. And, so something like a lateral meniscal tear may present very similarly. Or this blue area is where the lateral collateral ligament attaches or your outer hamstring attaches. So if the pain is more down in this area, this is at what's called the fibular head, it might again be more of a ligament or tendon injury versus IT band. But with a good physical exam, you can tease this out. So what are the keys to treatment? So years ago, I just tell this quick story. One of our top runners, I don't think he'll mind me giving his name, Mark Fidel, um, was came to Stanford, transferred in from Dartmouth, really, really good runner. And Mark developed this condition. And we tried everything throughout the whole year to get him better. And finally, I said, Mark, you know what? I think you need to see our surgeon because I just don't know what else to do. And Mark said, I don't want any part of that. I don't want surgery. And he heard about this massage therapist who was treating all these African runners with this really sort of innovative deep tissue massage technique. So Mark paid on his own, went, spent 2 weeks getting treatment, came back, he was cured. And we eventually got one of our massage therapists in town to learn this technique. And Mark actually, once he graduated from Stanford, then joined that practice and eventually took it over. And he was so committed to this and by the value of it. So just tell that story that initially, and we do this with our Stanford runners to this day, if they're starting to develop IT band, the first thing we do is get them with a good massage therapist to really work out any of the tightness in the IT band. This is a stretch you can also do. This is one of our former runners too, JJ White, who did this for his honors project in our biomotion lab. This is the typical way people do the IT band stretch here on the left. We found that if you add this overhead arm extension or reaching more diagonal, that will give you a bit better of a stretch. And when you go to massage therapists, you really want somebody who addresses not just where the pain is, but we found that you need to address what are called these trigger points, these hot spots in the muscle, all the way from up at your hip down to the knee and the IT band. So there's a really very systematic approach. And we found that if you don't address all of these, it's very hard to resolve this condition. Now, sometimes we do that, but patients still aren't, able to get back to running. So that's where an injection can be helpful. Now, the nice thing about, we'll use steroids for this, there's really no risk that you're going to injure the IT band with steroids. It's such a thick tissue. It's like with tendons, we don't like to put a lot of steroids there because there's a risk that it could lead to weakening, but you're not going to weaken the IT band. It's just very thick tissue. So an injection can be helpful. The other thing that we found is that one of the main reasons runners get this condition is because they're weak in their hip muscles. So again, this idea that if you're weak in the hip, it puts more stress on the knee. So both for treatment and for prevention, once we work out the soft tissue tightness, we do a lot of strengthening work for these outer hip muscles, particularly what's called the gluteus medius and the gluteus minimus muscle, because runners don't typically work those muscles on the side of their hips as much. When you're running, you're going more in what's called sagittal plane, forward and backward. You're not working those muscles on the hip, but every time you land, to control that femur bone from rotating inward, you really need strong outer hip muscles. So how do you strengthen these muscles? This is from a really nice article that examined all these different exercises. The side-lying hip abduction, so where you're raising your leg while lying on the side, was the best way to isolate the strengthening of the gluteus medius. However, a single limb squat was also very good, or the lateral band walk, people call it the monster walk, or a single leg deadlift. But this just gives you an idea of some good exercises here. Now, you may not want to start up here. You may want to start with something like a clamshell and then build up to some of these more advanced exercises. And when you're getting back to running, IT band syndrome is very unique. It's different than other types of running injuries. So I typically will say start off with a slower jog and then build up to more distance and then eventually start adding in speed. But with IT band, uh, runners will do better if they start off with more stride work, uh, with a little bit of a faster cadence. This helps keep them out of what I talked about, that impingement zone. Um, and so we've had some runners, for instance, some of our 800-meter runners, they couldn't run more than a mile, but they can still do their interval work on the track and they can still keep competing through the season, if they're still having some symptoms. So if you do have IT band, again, the approach to coming back is a little bit different. Start with some strides, start with hundreds and 200s and quarters, and then gradually build up from there. If we move down now to the tibia, there's a whole range of injury here called tibial stress injury. So you can have anything from what you might call shin splints or medial tibial stress syndrome all the way to a frank stress fracture. And I've come up with a grading system using MRI to kind of determine, exactly what grade you're at and how best to determine the treatment. But there's some easy tests you can do on your own, and this is something that our athletic trainers will often use to determine, is this something that where the athlete just see the physician, or maybe they can just do some cross training. So the signs that you should be concerned about, if the pain is not just diffuse on the bone, but if it's very focal, and so that if the band of tenderness is less than 10 centimeters, and particularly if it's really focused to just a couple centimeters, that's more concerning. And if they hop on one leg, and if that recreates that deep bone pain, that's also concerning, that there's something you're starting to develop a true stress fracture, or what we call these days more of a bone stress injury. It's more than just a shin splints. So if that's the case, at least for the tibia, not for all other bones, but the tibia, um, we have a little bit of leeway here because it even if you go to a fracture, it's not something that's typically going to need surgery. Um, so if you're concerned about you might have a stress fracture, just do some cross training, get in the pool, deep water running or swimming, or if you have access to something like this, an anti-gravity treadmill. Do that for 10, 14 days, and then gradually try to get back to running. If you're still having pain, then definitely be evaluated. You're going to need x-rays, potentially an MRI at that point. But you don't need to jump to that right away. You can try some cross training first. So why do runners develop this? One theory is that runners who develop this are not absorbing shock well. So that shock goes up to the tibia whenever they land. And this is correlated with having a stiffer knee. And by that, I mean when you land, the knee just doesn't give a little bit. So if we look here at this picture, if you look on the left, if you have more of a stiffer landing, there's less give at your hips. And so you're not able to absorb that shock, and that stress is going directly to the knee. If you have more of a softer landing, there's a little bit of give at your hips, and you're able to absorb that shock better before it goes directly to the knee. So in terms of prevention, learning how to land softer can be helpful. Also, as we mentioned with patellofemoral pain, if you can increase your cadence or transition to more of a forefoot strike over time, that's another way to decrease the stress, not only to the patella, but also to the tibia bone. So moving down, we've got two more injuries here, and then we'll have some time for questions. Achilles, what we call tendinopathy, so another one of these chronic tendon injuries. This is the most common tendon injury in runners. It's going to affect 7 to 9% annually of top-level runners. We do see it a lot more in males than females. Interestingly, though, we do see it quite a bit in more of our masters athletes, and particularly those who are not necessarily in great shape, who may have some other health conditions called metabolic syndrome, where you have high triglycerides, maybe high blood pressure. Um, and so, interestingly, they've associated metabolic syndrome with also being more prone to Achilles tendinopathy and some other tendon injuries. So sometimes the treatment is really just to address your underlying health, as much as focusing directly on what's going on at the Achilles. There's two main types of Achilles injuries. Now, the most common one is in the mid substance of the Achilles. So it's above the calcaneal bone, 2, 3, 4 centimeters. And you can see here, this is a side view. This is the tibia. This is the ankle joint. Here, this dark area is the Achilles. And you can see how it's rounded here. You have this focal nodularity. And that's where, as I mentioned in the hamstring injury, where those collagen fibrils become disorganized over time, the tendon becomes weaker. So the goal then is how to help heal this tissue. Now, oftentimes associated with this is you also have inflammation of the sheath around the tendon. That's called the peritendon. And so that could also be a cause of the pain, as well as what's going on directly inside the tendon. Biomechanically, we often see this Achilles problems associated with those who are overpronators or have what's called a forefoot varus, or they have limited ankle dorsiflexion. So when you pull the ankle up, or they may even have a discrepancy in their leg length. The initial treatment will just have athletes modify their activity. If I can, at all possible, have the athletes keep running. So maybe, they're okay on flat, but they can't run hills. If it hurts with any running, then we'll go to some type of other type of cross training, whether it's in the pool or bike, maybe elliptical or that Alter G. If you are a significant overpronator, orthotics might be helpful, or heel lifts can be helpful to take stress off the Achilles while it's healing. Stretching the posterior calf muscles can be helpful. A good way to do that is with you can just put your foot up against, let's say, a curve, straighten your knee and bend forward. And then you can also do it with your knee a little bent and bend forward. So that'll address both the gastroc muscle as well as the deeper soleus muscle. And then sometimes anti-inflammatories, this is non-steroidal anti-inflammatory drugs. Sometimes those can be helpful. It's usually not a cure, but we might do it for a week or two sometimes. The cornerstone of therapy is, again, getting the tendon stronger. And the best way to do that is, again, an eccentric exercise, because this puts the most stress on the Achilles is when it's eccentrically loading. And that's typically when it gets injured. So you want to strengthen the Achilles to withstand these eccentric loads. Initially, the studies came out of Sweden showing that patients who were getting ready to go for surgery, but there it takes a little while to have surgery, so they just put them through this simple exercise. It's called a heel drop. So you raise up on a step, and then you slowly lower, so the muscle's lengthening as it contracts. And they had them do quite a bit. So people in the study were doing upwards of 180 repetitions a day. So 90 with the knee straight, 90 with the knee bent. And they were getting at a success rate up around 80%. Newer studies haven't really been able to repeat that, about 50, 60% success rate. So it's not going to cure everybody, but it's certainly something that should be incorporated into your therapy program if you have Achilles problems. What are some of the other treatments? These are things you've heard about before when I talked about the hamstring tendon problems. So the shockwave therapy or the platelet-rich plasma, or there's something newer called percutaneous ultrasonic tenotomy, where you can take a needle hooked up to an ultrasound probe and actually suck out some of that thickened tendinotic tissue to stimulate the body to replace it with more healthy tissue. The other type of Achilles problem is down at the attachment, at the insertion, and this is a lot tougher to treat. The reason being is that oftentimes you'll have a bursitis here that's called the retrocalcaneal bursa, and also patients often have some extra bone here. So the tendon is getting impinged upon as it sort of drapes over the bone. So they'll have, if you look here on the right, they have this extra bone and it keeps rubbing against the tendon. So the eccentric loading programs for insertional Achilles tendon have even lower success rates, only around 32%. And if you do that, you just want to bring your foot down to neutral. You don't want to go too negative, or that's going to impinge that tendon against the bursa and the bone. Again, if you're not getting better, the platelet-rich plasma or the shockwave can be good options, or potentially that ultrasonic percutaneous tenotomy that I mentioned. This is a study that compared the PRP and shockwave, and the PRP was a little better when they followed the patients up at 6 months, but they were really pretty similar. So that's why I'll often start with the shockwave, because it's not invasive, and patients are usually able to keep their normal activity going, whereas if we do PRP, we really have to shut them down for several weeks afterwards. However, none of these treatments, PRP or shockwave, are going to be as helpful if you have that extra piece of bone called a Haglund's deformity or enthesophytes, other bone spurs in that area. Having said that, I did have a patient just this week who we did the shockwave on, who had the insertional Achilles with a big bone spur, and he said just after 3 treatments he's doing better, but overall the results are not as good. And these are the patients, more often than not, who are going to go to surgery if they're not getting better. Let's finish up with plantar fasciitis, and this affects 10% of the population. It's the most common cause of heel pain. In this case, it's more common with females than males. And it can get really confusing to try and figure out, what should you do for this? There's a million different treatments out there. And so I've tried to make sense of this in a paper I wrote a few years back. First thing you want to do is some specific stretches for the plantar fascia. Those are different than just stretching the calf muscles. You really want to do a stretch that really stretches that fascia, and there are specific ways to do that. An over-the-counter arch support or some heel cushions can also be helpful, or just taping the arch. And that's something a physical therapist can do, and it's very easy to learn how to do on your own as well. But you want to keep that arch taped all the time to supporting that arch will take the stress off the plantar fascia. And if you're not getting better, these are some of the treatments that had the best scientific evidence. So you may need a custom orthotic, something designed specifically for your foot. We could do a corticosteroid injection. I really don't like to do that with the plantar fascia because there is about a 10 to 12% risk that it could lead to rupture. So I tend to stay away from that with the plantar fascia and with the Achilles. But the other things that I've mentioned before, the shockwave therapy, the platelet-rich plasma, can be helpful for plantar fasciitis, similar to some of these other conditions we mentioned. Again, this is a study that showed that comparing the PRP versus the shockwave for plantar fasciitis, and found that PRP, again, was a little bit better, but the clinical significance of this was not very significant. One of the things we do for treatment as well as prevention is we focus now on what we call the core of the foot. And so you've got a lot of things that affect the function of the foot from what we call the neural subsystem, which are the nerves that go to that area, the different receptors on the uh, ligamentous tissues. And then you've got the active subsystem, which are the intrinsic muscles, the extrinsic muscles, and then just the plantar fascia, the passive subsystem, which is how your arch is shaped, uh, the stress on the fascia, and the different ligaments. There are a lot of muscles that attach at your foot. And unfortunately, because we wear shoes so much of our life, a lot of these muscles are not getting worked. And this is where doing some specific training, specifically to train these foot muscles. Uh, some people will call this foot yoga, um, but there are different exercises to specifically train uh, all these different muscles that you have in your foot. And eventually, over time, that can lead to a more supportive arch. And maybe you won't need, let's say, those inserts or the custom orthotics. But this takes time. It's not going to happen overnight. And then we have found it helpful to just have our athletes do some barefoot running a couple times a week. We'll have them do it on the grass infield. And that's another way to sort of naturally strengthen the foot muscles. Now, if you have plantar fasciitis, I wouldn't start this at that point because it might flare it up, but it's a great prevention strategy. So just go over some take-home points in terms of injury prevention. For the hamstring injury, hamstring tendinopathy, strengthening the hamstring eccentrically with those Russian Nordics, or there's other exercises that can do similar eccentric strengthening, can be helpful. Avoid overstriding. For patellofemoral pain, strengthening those outer hip muscles, particularly the hip abductors and the external rotators, can be helpful not just for treatment, but for prevention, and as well as considering a forefoot strike or increasing your cadence. For IT band syndrome, regular deep tissue work, stretching, using your foam roll, and keeping those outer hip muscles, the hip abductors, strong can be very helpful, not just for treatment, but for prevention. For tibial stress injuries, I didn't mention it, but they found in the military, if you wear shock-absorbing insoles, that can be helpful. But you can also do this by retraining your gait to land softer at impact, or also going to more of a forefoot strike or increasing your cadence. For the Achilles, again, it's a tendon issue. We want to strengthen the tendon, but to progress to where you're doing eccentric exercises. If you are an overpronator, that is something you're going to want to address, whether with a shoe insert, maybe initially, or a custom orthotic, but definitely want to also strengthen your foot with some of those exercises we talked about for plantar fasciitis. And then finally, for plantar fasciitis, doing regular stretching, massage of the plantar fascia can be very helpful for prevention, as well as that core foot strengthening. So let me stop here, and then hopefully we can have enough time to get to some of the questions.
Thank you so much, Dr. Fredericson. Can read a few questions out. Do you have any advice on specific running shoes in terms of the thickness or stiffness of shoes and how they may affect the risk of injury?
Yeah, shoes is always tricky. Most important thing, rather than a specific brand, is you want to find a shoe that's comfortable. So that's number one. What can be helpful is to figure out what is your foot type. And so when you go to a shoe store, particularly like a running specialty store, you look on the wall and they're going to have three main types of shoe categories. They're going to be the cushioning shoes, so something like the Hoka. You'll have more of your stability shoes, which have some cushioning, but they've got also some good support. And then you've got motion control shoes, which are give you a lot of support for those who are real significant overpronators. So if you've got a good arch, but let's say you're not absorbing shock as well, maybe you've got some arthritic joints, a more cushioning shoe might be helpful. Something like, let's say, a Hoka. Although some patients don't like Hokas, it does not work for everybody. Um, if you have more of a neutral arch, you want some cushioning, some stability, then you want more of that stability shoe. If you're really an overpronator, um, you're probably going to want to go with the uh, more motion control shoe that gives you a lot of arch support. It's got a real firm, they're stiffer shoes. The heel counter is also very stiff. Um, so that's really the best recommendation is figure out your foot type, try on the shoes more specific for that foot type. I would be careful though if you go into some of these really lightweight shoes that are trying to simulate more of a barefoot approach, because if you're somebody who does need more stability and more support, if you do that without strengthening your foot, you may actually cause foot problems in doing this.
Thank you. Is there a resource that you would recommend for stretching and strengthening exercises, where to find them, or videos?
Um, so just some shameless self-promotion. I have written a book combining foam roll with stretches. It's called Foam Roller Techniques. I think you can still find it on Amazon. And so I wrote that actually with Mark Fidel, who is the massage therapist I mentioned. And so we kind of combined our knowledge to come up with, and we went over different stretches and how to use the foam roll really for every part of your body. So that can be a good resource. But if you go online too, there's a lot of good things you can find in terms of stretches for runners.
Is there anything that runners in perimenopause and menopause should consider?
Well, when you're going through that and your hormones are shifting, I would just say that I have found that it is a time when you might be a little more prone to injuries, particularly some of these tendon injuries. And so I would just be a little bit more careful to not push through pain, be a little bit more aware of what the sensations are in your body. Um, there was one question we got beforehand in that they said that they are going in the perimenopausal phase right now. Their back hurts consistently. They're doing core exercises, anything else you can do. Um, Really an overall body conditioning, so maybe a more, not just your core, but overall body strengthening, maybe doing some weight training and things could be helpful as well.
Great. What about meniscus tears? Do you have any advice on that?
Yeah, so there's two main types of meniscal tears. So there's the acute tear that's going to occur, and that's more commonly in sort of your, younger athlete, 20s, 30s, we'll call younger. Um, and those, typically have like a normal meniscus, something happens acutely, and then you've got a tear there. Um, those, will often need surgery. As we get older, we tend to develop what are called more degenerative meniscal tears. So our meniscus tends to wear down over time, and then you do something and you flare it up, and let's say you get an MRI, you're like, oh my God, I've got a tear there. But because this is something that was probably building up over time, these will often calm down just with some modified activity, physical therapy, and oftentimes doing a steroid injection into the joint. And so um, if you do develop that, uh, let's say you're in your 40s, 50s, 60s, and beyond, and you develop that, it's a meniscal injury, you don't really need to jump to surgery unless you have more what we call mechanical symptoms. So you can't straighten the knee, you feel something clunking in there. But if it's really more just pain, it's reasonable to try a non-operative approach first.
How can runners avoid overuse injuries while they're training for half marathons or marathons?
The biggest thing we say is, you know, too soon, too fast, too hard. And so it's really the more experienced runner where we're going to see more of these injuries. And usually because you're just trying to ramp up too quickly for what your body can handle. So just be patient with yourself. Don't compare yourself to other people. Um, you know, there's a lot of these marathon training programs that are great, but some of them are only 3 months, and that you may need 6 months, you may need a year or so to really, ramp up to that. So just try and be patient with what your body needs to get ready. The other thing I would say, and in our runners injury prevention clinic, we always say, don't run to get fit, but first get fit to run. So if you think, oh, I'll just start running, but I haven't been doing much exercise, and that will get me in shape, that might not be a great idea. You might want to actually do some general fitness exercises first, get your body stronger, and then run. So
Somebody
hopefully,
would like, yeah,
yeah.
thank you. Somebody would like to know if being naturally pigeon-toed could increase the risk of injury.
It might. People who are pigeon toes oftentimes have more of a high arched foot. And so we talk about the sort of a lower arch foot. Those are the people that may need more arch support. They may be the overpronators. A high arched foot is one that doesn't absorb shock very well. So in that case, you may need more cushioning because if you can't absorb the shock at your foot, it's going to go up, whether it's to the ankle, the knee, it may even go all the way up to your pelvis. I saw somebody today who had a stress fracture in her uh, pelvic area, and we were able to relate it to her having a very high arch.
Do you have any supplement recommendations and hydration recommendations for running short and long runs?
So, some of the things that have come out lately, uh, uh, nitrate, so beets can potentially be a helpful way to help with endurance, potentially help with inflammation that might occur. Uh, a good turmeric supplement, I think, can be very helpful at controlling inflammation, or just, use a lot in your cooking. If you know that you have arthritis, um, then a glucosamine supplement might also be helpful. The studies on that, are somewhat all over the place. Some show it works, some show it doesn't. But if you talk to veterinarians, they'll tell you it works in animals. So there's something to it. Now, is it actually rebuilding the cartilage, or is it helping with inflammation? Um, there's no significant side effects to it. So I think that's a reasonable option too, the glucosamine with chondroitin.
Thank you. And how about hydration needs for both short runs and long runs?
The current recommendations are really to go by what your natural thirst is telling you. Um, what we so to have some electrolytes can be helpful, but you don't want something too concentrated like Gatorade. You want it much watered down, maybe with a little bit of salt, a little potassium in there. Um, If you are running a marathon, let's say, be careful of drinking too much water. Uh, Studies have found, and a good friend of mine who directs the Houston Marathon has done studies on this, that if you're drinking too much, let's say you're out on the course 4 or 5 hours and you're drinking all the time, you might actually take in too much water and then you dilute your sodium, and it's called hyponatremia, and you can actually die from that. And runners have died. So, um, really, you want to drink regularly, but drink according to what your thirst is telling you as well. The other thing to do is just, weigh yourself before and weigh yourself after. And that gives you a good idea how much fluid you lost and how much you need to replace.
How can you know when to return to running after injury and physical therapy?
Well, hopefully a good physical therapist helps guide you with that. So, you're doing all the exercises, you're pain-free, and then they put you through what are called functional exercises. So things that simulate running or another sport you're going to do, and you're still doing well, you're not having pain, your biomechanics look good. That's going to give you some reassurance that when you go back to running uh, or another sport, that you're going to be okay. Uh, but again, keep in mind that just because you do the exercise great in the gym doesn't mean your biomechanics are going to be great when you get back to your sport. So if somebody can watch you run, do some type of analysis, whether it's a coach or a good physical therapist, um, that can be really helpful just to make sure that you've incorporated the benefits from the strengthening back into the actual biomechanics of your running. And then start slowly, don't ramp up too quickly. Start really slowly. We talk about the 10% rule. Don't increase your mileage by more than 10% per week. Start off at maybe 10, 20 minutes of running max, and then just gradually increase from there.
Well, thank you so much, Dr. Frederickson, for sharing all this great information. And thank you to our audience for joining us and all the great questions. If you'd like additional information or resources, please contact Stanford Health Library. And we hope you enjoyed tonight's talk, and we hope you'll join us for our next lecture.
Great. Thank you.